Hi, my name is Lori Clemens. I am a graduate nursing student at Mount Mercy University. My focus for my degree is forensic nursing. I am currently the director of a sexual assault forensic examiner program in the state of Rhode Island. It is a hospital-based program. The acronym is SAFE for our program. And my poster presentation today is on the implementation of a sexual assault forensic examiner or SAFE preceptor training program in our new hospital-based SAFE program. So in considering this project, looking at the current SAFE program, our program was only established in January of 2023. Our team consists of 28 safes at this point in time. It has taken the staff a bit of time to gain experiences and feel comfortable and confident conducting medical forensic exams within our program. Each of these safes come with a varied nursing experience. We also have physician assistants within our program. So I took this initiative on because up until this point, leadership within the program, which includes myself and my medical director, were the ones tasked with precepting all of the new staff that have joined our team. Additionally, some background for our state. There has never been a coordinated sexual assault response program, so there is not a large pool of sexual assault nurse examiners or sexual assault forensic examiners to pull from in terms of experience within the state of Rhode Island. So for this project, in addition to the research on what current practices and preceptor training programs offer in terms of enhancing education of staff, I looked at 7 SANE and SAFE programs. This also included a telesane program in the state of Massachusetts. So the programs that I looked at included Massachusetts, the state of Maine, that has a SAFE program, the state of Connecticut, and the state of New Hampshire, in addition to the International Association of Forensic Nurses education guidelines and also recommendations for preceptorship. I additionally attended the hospital itself, which is Brown University Health, formerly known as Lifespan Hospital System. They have a generic preceptor training program for both inpatient and ambulatory settings throughout our hospital system that includes 4 hospitals. So I was able to attend that and gain some insight as to what is offered in our current hospital system. And what was noted throughout this research process in assessing what is currently existing in SANE or SAFE programs, but there's a lot of variation, and the training that exists mostly focuses on the SANE role or the SANE tasks that are included throughout the medical forensic exam and ensuring that the SAFE preceptors have competency with those tasks. However, there were only a few programs, which included the Massachusetts SANE program and their telesane program included information related to providing effective feedback, effective communication, and other essential components to being a preceptor and a role model for new novice safes. In looking at the literature, it is a common practice that SAFE or SANE programs require and depend on previously trained and expert safes to share their knowledge and share their expertise. So not only do they need to have a pool of experienced SANEs or safes to pull from to train and precept new novice SANEs, it's challenging to sort of solicit and have that pool who's at the ready, who are actually willing to continue to educate the newer staff. There does not seem to be a consistent way to continue to evaluate preceptors. There also seems to be some variations in practice for programs that do not have a consistent group. So for instance, Maine had expressed that they have a lot of challenges in recruiting preceptors for their program, and the New Hampshire program relies still, even though they've existed for some time, on their primary leadership to continue to precept all of their staff and their preceptors. Additionally, in the research, what was noted was that by elevating staff into the preceptor role, this contributes to program sustainability, staff engagement, staff feel valued, and then the programs that seemed most successful offered additional compensation, of course, for taking on this preceptor role. The other themes that were identified focused on, as I mentioned, the programs tended to focus on preceptor competency for the tasks that occur during the medical forensic exam, but not necessarily focused on how do I teach somebody and how do I teach somebody appropriately in the clinical environment when you have a patient in front of you who's been traumatized, and how do I do that with appropriately and respectfully with a new novice SANE. So for this particular project, the gaps and challenges that were identified, we did not have preceptor credentialing or readiness because it was a new program, as I mentioned. We had just launched in 2023 in January. We started seeing patients at that time. So leadership was the second challenge. The time it takes to precept takes away from program oversight and management, and then also continued development of the program. As I said, we took on currently 28 SAFEs who are doing this work, and they all develop at their own pace. So some SAFEs in training require just one exam, especially for the APRNs or the physician assistants who are used to sort of jumping in into new situations and have advanced education. They're more comfortable in this new role. However, on average, what was noted for our particular program when I was looking into this, on average it takes 2 to 3 medical forensic exams with a preceptor to feel comfortable in terms of all the aspects of care, the operational components of the role, in addition to medical forensic documentation, and all the other competencies that come with the SANE role or the SAFE role. There's also obvious limitations in having one individual or two individuals precept all team members. The more variety, if there's training involved and for preceptors, lends to consistency in practice and also creativity when you see how other people may approach a patient or have a way of speaking with them or have a better way to organize their workspace. so we can learn from one another. So this was one of the reasons that we identified a Preceptor program as the next important step for our program. In terms of the planning, we did divide this into 2 phases because of the nature of time that it takes to set this up. We determined what our preceptor criteria would be. This included everything from the number of years that they were practicing as a SAFE. So again, I've had people trained in our team almost 2 years now. So that was sort of the set criteria for our program. But in addition to that, I did look at the way their documentation had been in terms of their case completion, what were their numbers, and on average, most of our the preceptors selected, we ended up selecting 5. They have a case completion of over 12 cases on average. Some have actually increased since creating this poster to 15. So our program is getting busier, and we wanted to ensure that they had enough case experience to take on this new role. So in addition to the criteria, we developed the education. So I developed an education model that was a live virtual model that was presented to our selected SAFE preceptor candidates. We used the research, the evidence-based research, as well as the current programs to identify those essential components. And what we landed on for our education model was to include not only pearls or clinical pearls that would include important components of the medical forensic exam, such as ensuring proper documentation and obtaining clinical history, proper documentation of patient injuries, using the forensic photography techniques that we all received in training. We also felt like it was important to include adult learning theory, providing communication and appropriate feedback, using sort of gentle reminders and prompts and respectful communication throughout the process, and also incorporating teaching in real time in a clinical setting in front of a patient. By teaching the patient, you're also teaching the preceptee in that moment. So that also supports sort of respectful and adult learning theories. So we developed several materials for this project. In addition to the education model, we developed a pre-self-evaluation to determine what were the candidates' feelings about taking on this new role. We also developed a post-training evaluation, and we've now developed a preceptor competency checklist, which will be utilized to evaluate each of the preceptors periodically. Initially, we have them all scheduled, and this is part of phase 2, to be accompanied to a sexual assault case in the emergency department by one of the leadership. So that includes myself or my medical director, to evaluate them with this checklist. We also developed a post-preceptor case evaluation. So the leader will provide this, or they will be provided this after they do their precepted case by program leadership. And then we also, so we conducted the training on 11/25. All of the candidates did complete the self-evaluation prior. They also all completed the post-evaluation for the training. And then additionally, the plan is to have preceptors be evaluated by whoever they're precepting in the future. And that checklist, and it's actually a REDCap survey, has been created and will be implemented so that the new candidates that we have recently hired will be able to use that. So again, for implementation, each of the candidates' qualifications were reviewed to ensure that they met the criteria that we all established. And this was reviewed with my medical director. And again, we landed on that they needed to have at least 2 years experience and a minimum of 10 to 15 cases completed. In addition to that, we looked at their documentation to ensure that was something, again, that was rooted in best practice for medical forensic exams. We also looked at the completions of their charts, and I also looked at whether or not they were consistent with their communication. So in terms of our program, we do debriefing after every case. We also, because we are a new program, we do have them reach out to my medical director or myself to discuss cases prior to their response to the emergency department, especially when cases are complex, to make sure that they have the support they need and can answer any questions before they head to the emergency department. So these candidates they all met criteria. They all routinely communicate in a very positive way with leadership regarding cases and do reach out to debrief consistently. As I mentioned, they all met criteria regarding case completion, and their documentation was up to the standards that we were looking for. Each candidate, like I said, completed the pre-self-evaluation survey. We conducted the training, and they completed the post-training evaluation. They have all been scheduled for phase 2 in the next several weeks. We will use that competency checklist for our preceptors, and then they will complete the post-case REDCap self-evaluation and debrief with leadership to identify any additional learning needs. As I mentioned, we developed the REDCap survey for those that they'll be precepting in the future, and that is ready for implementation with those individuals. So in terms of evaluation of this project, overall, the feedback that received from self-evaluations was very much aligned with the research that I had conducted, which noted that most people who are voluntarily or selected for preceptor roles feel pretty confident about taking on that role. And that was a very notable comment that we received during that self-evaluation prior to training. The feedback post-training identified some themes, and they did note that they felt more prepared after reviewing some adult learning theory and communication and feedback suggestions, in addition to reviewing some of the clinical pearls that we reviewed during the learning module. It gave them opportunity to discuss amongst themselves concerns about feedback, providing feedback in real time in clinical settings. They also asked if they could go out and precept or do case completions with each other, which I thought was an excellent idea that came out of this initiative. And that will be something that we'll be implementing, and actually some have already signed up to go out and with each other. And the program will support that is able to support that financially at this time. In addition to that, some of them asked for more information and training. And the next steps for this initiative is that that's come out of this initiative, I should say, is that we're going to implement a check-in training. So a 6-month training, once everybody is sort of up and running and precepting, 6 months we will have an additional training. And what they ask for is information and case reviews, which we do routinely as a team anyway, but from a preceptor perspective, to talk about more complex cases, ensuring that they have the knowledge and information that they can share with new and training sexual assault forensic examiners. I'm happy to take any questions. I appreciate you listening to my poster presentation today, and I hope you found it interesting. Thank you.